Hello, my name's Dr. Roger Henderson and I'm a GP in southwest Scotland, and I also co-host the GPnotebook study groups. Welcome to this GPnotebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. Now you can find us on all major podcast platforms, including Apple Podcasts, Spotify and Google Podcasts. So do please follow us to receive notifications about new episodes, and if you like what you hear, do please consider leaving a review to help other listeners find us. You can also follow us on Twitter at GPnotebook for more information about new podcast episodes and study groups, and you can find me there too at Roger the Doctor. Finally, you can visit GPnotebook.com for podcast episode show notes and to find out more about upcoming study group meetings. Now, in this episode, we're going to be discussing generalised anxiety disorder, potentially a huge topic, so I just want to go through some of the bullet points we should be remembering the next time we're considering this diagnosis in a patient sitting in front of us. Going back as far as Freud, he coined the term anxiety neurosis when he was actually thinking about generalised anxiety disorder in the patient sitting in front of him. And the ICD-10 classification first came up with the formal term generalised anxiety disorder, or GAD, and classified it as a syndrome of ongoing anxiety and worry about events or thoughts. Well, we all have those, but the key thing here is the patient generally recognises as excessive and inappropriate. And GAD can also be highly debilitating and chronic. The lifetime prevalence of generalised anxiety disorder is around 5%, with a current prevalence of 2 to 4%. So these are significant numbers, and men are generally slightly more affected than women. We also now know that GAD is more prevalent in the elderly than we previously thought. If we look at risk factors and protective factors for people suffering from GAD, we now know that risk factors include being generally middle-aged, by which I mean aged from 35 to 54. Other risk factors include being divorced or separated, and also anyone living alone or who is a lone parent. Protective factors are being younger, aged 16 to 24, and then either being married or cohabiting are also apparent protective factors. If we look at the DSM-5 diagnostic criteria for generalised anxiety disorder, these say that we have to have excessive anxiety and worry, and the term apprehensive expectation here is, I think, highly appropriate. So you worry excessively, and then you are certain that you are going to be hit by a bus or something is going to land on your head. And these occur more days than not for at least 6 months. It is very difficult to control the worry, and also to make the diagnosis, this requires muscle tension or restlessness. So we need excessive anxiety and worry that occur more days than not for at least 6 months. The worry is very difficult to control and there is associated muscle tension. Plus, we must have symptoms from autonomic arousal symptoms, chest symptoms, mental state symptoms, general symptoms, and non-specific symptoms. So, by these I mean autonomic arousal symptoms, typically things like palpitations, sweating, and a dry mouth. For the chest and abdominal symptoms, we would have things like dyspnea, chest pain, and nausea. Mental state symptoms could include things like fear of dying, depersonalization, and dizziness. General symptoms could be things like a lump in the throat, feeling hot and cold, or having generalized tingling. And non-specific symptoms can include things like easy startling, irritability, and insomnia. There are a number of potential differential diagnoses when we're looking at generalized anxiety disorder, and confusion and overlap are common, unfortunately, which can make our job a little bit more difficult. So I'm thinking of things here like panic disorder can be typically confused with GAD, plus or minus agoraphobia. Obsessive compulsive disorder can give us shades of grey when we're thinking about GAD, as can post-traumatic stress disorder. Any phobias can be a differential here, including social phobia, and obviously we can't discount acute stress as a possible differential. We might also want to just remember things like alcoholism, schizophrenia, dementia, and on occasion physical illnesses, but these are less likely because we're thinking about things like pheochromocytomas here and undiagnosed and untreated significant thyrotoxicosis. But always remember the key thing here when we're looking at differentials about GAD diagnostically is that the worry and the anxiety and the apprehension is out of all proportion to the circumstances. And these are widespread worries that shift and involve typical everyday issues. Now, should we be screening for people with GAD? Well, there are a number of screens out there. They have limitations, but the consensus is that they are worth employing in evaluation and treatment. And the three typical ones we could look at here would be the Beck's Anxiety Inventory, the Hamilton Anxiety Scale, or the Hospital Anxiety and Depression Scale. So it is worth just downloading these online and having a look to see which you feel may be the simplest for you to use. Nice talk about general points for managing our patients with GAD, and the obvious one they say here is to identify our patients with it as soon as possible, and that goes without saying, I suspect. We should also ask our patient what preferences they may have for their treatment options, and to inform them about the condition as much as possible. We now know that long-term, the best results when we're treating our patients with GAD are from psychotherapy, followed by medication, followed by self-help. And the placebo response with GAD can be very significant, between 20 to 50%. Referral obviously is an option, but we should only be referring the most difficult cases for specialist appraisal. And NICE have come up with their stepped care model, which is essentially 4 main steps. So step 1, which is all known cases of GAD, should be assessed, should be educated, monitored, and advised. Step 2, where we have diagnosed GAD that is not improving after educating, then low-level psychological support and self-help should be the treatment. For GAD that is not responsive, at that point, we should look at CBT or drug treatment, and only refer for stage 4, which is complex treatment-resistant GAD. But do remember, there are frequently comorbid conditions such as depression or drug abuse that may also need treating, and NICE recommend that the most severe condition be treated first. If you're treating a child or an adolescent, always obviously be much more cautious about prescribing and get your specialist involvement in early. So let's look at pharmacological treatment, but before prescribing anything, consider a number of things, including the age of the patient, whether they had had previous treatment and their responses to that treatment, the risks of overdose, how tolerated those pharmacological treatments are, and whether there are medication interactions. Ask what the patient preference is, and also think about cost where things are equally effective. So, if we need a rapid response in practice, then we can consider a sedative antihistamine or a benzodiazepine, with all the caveats that go with prescribing benzodiazepines. But these obviously should be used short term, ideally for 2 weeks or less. Now, buspirone is less sedative and addictive than benzodiazepines, but we should still be using that with the same caution. And we may consider apparent dependence in our patients on short courses of benzos, and this may be due to genuine dependence, or in the case of JD, because the disease has returned as the drug is withdrawn. And so we may need to look at antidepressant treatment, which is good at alleviating anxiety, even if there is no true depression. Now, obviously, their onset of action is slower than benzos, but can be used for longer and with a lower risk of long-term dependence. Now, NICE say that an SSRI or venlafaxine could be used as the first choice, and actually suggest sertraline first line, although this is unlicensed for GAD, but the licensed SSRIs for GAD in the UK are paroxetine and escitalopram. Always obviously inform the patient about potential side effects, and very importantly about the delay in the onset of any improvement. Treat them for at least 8 to 12 weeks, but if there's no benefit after that time, it is worth trying a different class of antidepressant and tailing off SSRIs and venlafaxine if they're on those. If you've got a patient who genuinely cannot tolerate an SSRI, then pregabalin is well worth considering. But we mustn't forget what the MHRA said in 22, where a new study suggested that using pregabalin may slightly increase the risk of major congenital malformations if used in pregnancy. So if we are putting someone on pregabalin for GAD, those patients should continue to use effective contraception during treatment and avoid any use in pregnancy unless clearly necessary. Although NICE don't mention this, duloxetine is licensed for GAD and can be effective, but there's no good evidence to guide us about how long we should use it. Beta blockers and MAOIs, which have been used in the past for GAD, are now not usually considered appropriate options. Looking at self-help, which is very effective, it is best used as part of a stepped care approach. And we tend to use this systematically over 6 weeks with occasional therapist contact. And post-COVID, phone calls or online consultations appear to be effective, even though the evidence base is quite small at the moment. Aerobic exercise may help short-term as an adjunct, but if 2 interventions haven't helped, then at that point I would suggest we should be referring. When we're monitoring our patients with GAD in primary care, I would suggest we do this every 4 to 8 weeks, and if they're on treatment, medication, then NICE recommends review every 2 to 4 weeks for the first 3 months, and then 3 monthly, continuing treatment for at least 1 year. And if at all possible, monitor the outcome with a self-complete questionnaire. So we should be thinking of generalized anxiety disorder as a chronic disease rather than acute one, and one that is often controlled rather than cured absolutely. We know it waxes and wanes, so long-term support and education of our patients is required, and we also now know that chronic anxiety conditions are associated with increased morbidity. So I do hope you found that quick overview of generalized anxiety disorder helpful, and thank you for listening. But do have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you'd consider following the podcast and leaving us a review on your favourite podcast platform. It really does help. Do feel free to get in touch via social media at GPnotebook, or email us support@gpnotebook.com if you have any questions, comments, or ideas for future podcasts. We really do like hearing from you. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups that occur all year round, and to download free shortcuts to help improve the lives of our patients in primary care. But as always, until the next time, thank you for listening and goodbye.